Welcome back to a Pediatric Dentist channel Tiny Teeth Talks. If you are new to this channel, subscribe the channel, and for details of this channel visit the bio section, or you can also check out my previous videos. We are back with non-pharmacological behavior management techniques. So today we will cover pre-appointment behavior modification, communication, descriptive praise, signaling, and euphemisms. Behavior modification start before the day of appointment. So starting with the pre-appointment behavior modification. It includes pre-appointment communication, audiovisual modeling, and positive pre-visit imagery. So starting with the pre-appointment communication include mailing and calling. So pre-appointment communication, which often involves a combination of mailing and telephoning, is a fundamental component of pre-appointment behavior modification. Its primary goal is to manage parental anxiety and set positive expectation for the child's first visit, thus dramatically increasing the likelihood of a successful cooperative appointment. Many parents transfer their own negative dental memories or anxiety to their children, sometimes unintentionally. So, pre appointment communication provides a controlled environment to address these anxieties direct. The communication includes positive philosophy, a brief introduction to the practice's child focused philosophy. Like, we believe in fun, gentle dentistry. Then instructions for parents. Specific crucial advice on language to use. Use counting teeth instead of drill. Language to avoid like hurt, short, pain. This is the most important element for behavior modification. First visit expectations. An outline of what the first visit entails, like a simple examination and cleaning, not extensive treatment. Office policies, information regarding parental presence in the operatory, and some cancellation policies. Parent can be contacted by telephone as a reminder the day before the dental appointment. It may serve in establishing good relationship. Positive philosophy focuses on making the child feel safe, respected, and happy during their visit, shifting the focus away from the procedures and fears. It is a communication tool used to manage the expectation and anxiety of both the child and parent, with instruction for parents to avoid some words and language to use in front of child. And first visit expectation, what will be included in first visit: a simple examination and cleaning, and some office policies that from this age to this age parental presence should be necessary in the operatory room, and after this age parental presence are not required in the operatory room, and some cancellation policies. All these things included into the pre-appointment communication. Then second is audiovisual modeling. Audiovisual modeling is a powerful behavior guidance technique based on social learning theory by Albert Bandura. So we already uploaded long detailed video of all the theories of child psychology on our channel. Go check it out there. So it is a form of vicarious learning where an individual, means the child patient, learns new behaviors or modified existing ones by observing the actions and consequences experienced by another person who is the model. Child sees the video cassette before proceeding to dental clinic on the day of appointment, and the type of model used can be siblings, other children, or parents. So the video is most effective when shown immediately before the first or a complex dental visit, often in the waiting room or a separate consultation area, or even sent to the family to watch at home in the days prior. This ensures the learning is fresh in the child's mind. Which type of models should be included in the video? So the peer models, other children, these are often the most effective. The child can easily relate to another child undergoing a similar experiences. Sibling models, if the sibling is cooperative, this can be highly effective due to the personal connection. And parents, which might be a less common but possible, especially to demonstrate cooperative adult behavior, like sitting calmly in the chair. So it is the best recommend to use the model of the same age as that of the child patient, so that he can easily relate himself with the model. And research also suggests that the maximum behavior benefit is achieved when the child model is of a similar age or slightly older than the observer. These increase the child's feeling of self-efficacy, the belief that they too can successfully perform the behavior if a peer can. Advantages of this modeling technique are stimulation of new behavior. It is excellent for teaching children, especially especially those new to dentistry, the appropriate way to behave in a dental setting. Facilitation of behavior in more appropriate manner. It helps children who are familiar with the dentistry but still exhibit more uncooperative tendencies. Elimination of inappropriate behavior because of fear. By showing a model who is not fearful and is reinforced for cooperation, the observer learns that the situation is not dangerous, reducing fear driven misbehavior. Extinction of fear. Observing a model successfully cope with a potential anxiety provoking situation act as a form of vicarious desensitization. Okay, vicarious desensitization here, because this is a specific type of behavioral therapy technique used to reduce or eliminate fear, anxiety, or phobia through observational learning. That's why it is called the vicarious desensitization, that helping to extinguish the fear response before the child even sits in the dental chair. Disadvantages are expensive. Creating high quality professional videos with a good audio, lighting, and engaging presentation can be costly for a private practice and time consuming process. It takes time to develop, taste, and administer the program, like making sure every child watches the relevant video. However, the time saved in the operatory due to better cooperation often offset this disadvantage. Then the third is positive pre-visit imagery. So positive pre-visit imagery involves the strategic use of visual aids to manage a child's expectation and reduce anxiety by making the unfamiliar dental environment seem familiar and non-threatening. Patients are shown positive photographs and images of dentistry and dental treatment in the waiting area before the dental appointment. Positive pre-visit imagery can be displayed in a various formats like posters and wall art, so murals or framed photos showing smiling children in the dental chair. Then photo albums or tablets, a collection of high quality positive photographs available in the waiting room. Digital signage, so slideshow running on waiting room screens. The content, the images strategically focus on the environment, photos of a bright, friendly waiting room, the cheerful staff, and child size equipment. The process, images of child riding the dental chair, having their teeth counted with a mirror, or receiving a sticker for cooperation. The instruments, close up of non threatening instruments like the tooth counter, which is mirror, the water squirter, which is air water syringe, being used gently. Scary items like needle, plier are never shown. The objectives behind these are to provide children and parents with visual information on what to expect during the dental visit, to provide children with context to be able to ask the provider relevant questions before dental procedures are initiated. Then after pre-appointment behavior modification, the second is communication. Before you can treat a child, you must first become their friend and guide. So communication is the tool that breaks down the barrier of fear and builds a connection. So first objective in successful management of young child is to establish communication. By involving the child in conversation, the dentist not only learns about the patient but also may relax the youngster. The fears and natural innate curiosity of child demand that explanation be given for each and every step of the dental treatment. There are two ways of communication, verbal and non-verbal. So verbal communication includes spoken language, so using spoken words to gain confidence and provide instructions. Children aged 2 to 7 years are often in the pre-operational stage, so where they think magically and use animism, that giving life to inanimate object. So dentist must use effective vocabulary which should be simple, non-threatening, and include imaginative words like calling the handpiece whistling Charlie or Mr. Bumpy Brush gives the scary noisy tool a playful personality, making it less threatening. The suction tube becomes Mr. Thirsty and the air water syringe becomes Mr. Water Spray. Honesty is a crucial for building long-term trust. If a procedure is going to be slightly uncomfortable, like getting local anesthesia, the dentist must be honest but gentle, saying something like, "You might feel a tiny mosquito pinch or a wiggly feeling." If the child knows the dentist is honest, it leads to cooperative behavior. Then the non-verbal communication, like expression without words. So actions and body language used to reinforce and guide behavior, often more powerful than words. A genuine welcome handshake, a gentle pat on the shoulder, and maintaining consistent eye contact. Non-verbal communication is the reinforcement and guidance of behavior through appropriate context, posture, facial expression, and body language. The objectives are to enhance the effectiveness of other communicative management techniques. For example, when using tell show do, a dentist must maintain a calm, smiling face, a relaxed posture, which is included in nonverbal communication, and these nonverbal reassurance reinforce the verbal message that this is safe, gains patient attention and compliance, and motivates him. A quick firm yet gentle hand on the shoulder can immediately stop a child from moving and refocus their attention, conveying a message of be still now, I'm serious, but everything is okay. A smile after a successful part of the procedure is powerful non-verbal form of positive reinforcement. For the successful communication, the communication triangle should be completed. So the three most important facets of communication are source, medium, and receiver. So the source, the dentist, must be sympathetic, confident, and honest. Medium, the dental clinic, must be neat, quite familiar to children, and inviting, perhaps with toys. And the receiver, the child, who receives and interprets all these signals. So if the source and the medium are positive and well managed, the child, who is the receiver, will automatically communicate and be well managed. The entire environment communicates safety and trust. Now, the third is descriptive behavior. You can also say descriptive praise, also known as labeled praise or specific praise, is a crucial technique in pediatric behavior modification. It is a targeted form of positive reinforcement that goes beyond simple approval to guide the children's future actions. So, descriptive praise tells the child exactly what action earned the praise, making the desired behavior clear and easy for them to repeat. This is essential for teaching the child the rules of the dental visit. One simple example is the behavior is sitting still, opening wide, keeping hands in the lap, letting the mirror touch the tooth. So the praise statement should be thank you for sitting still like a statue. And the reinforcement is the child feels recognized and good about themselves, making them more likely to repeat the action. Some practical examples: child hold still for the examination. So in general praise you say good, but descriptive praise include thank you for being such a great statue that helped me see all your teeth. Another example is child keeps their hands away from their mouth. In general you say you are doing well, but descriptive praise says I appreciate you keeping your hands resting on your tummy. That makes our job safe and fast. A child opens wide during suction. In general, great opening. But in descriptive praise, your mouth is open so wide I can see all the way to your back teeth. That's exactly what we need. Child uses the signal like raising a hand. So, in general, thanks for stopping. But in descriptive praise, thank you for using your signal. Let's take a quick breath and then we'll continue. So, objectives and benefits are it clarifies expectation, it clearly defines the cooperative behavior, removing any confusion for the child about what the dentist wants them to do. Increase repetition by immediately rewarding the specific action, the behavior is reinforced, making the child more likely to perform that exact action in next minute or at their next appointment. Build self-efficacy. It teaches the child that they have the ability to successfully participate in their care. I am good at being a statue. This sense of achievement reduces the anxiety. Enhance rapport. It shows the dentist is paying attention to the child's efforts, strengthening the relationship built through the communication. Then the fourth is signaling. Signaling allows the patient to communicate with the dental team during any phase of treatment by means of previously established signal with the specific meanings. So how it works? So there is an agreement before the child and the dentist. So before the procedure begins, the dentist explain and agree upon a clear non-verbal signal with the child. And the simple signal, the standard and most effective signal is raising one hand or a finger. The meaning is always the same. Stop immediately. immediately. It signals the child's wish to stop the treatment, whether for a rest break or to swallow, or to notify the dentist of any unpleasant feeling. Response and reinforcement. The effectiveness of technique relies entirely on the dentist response. So child signals, the child raises their hand, dentist stops. The dentist must stop the procedure immediately, turning off the hand piece, removing the instrument from the mouth. Communication. The dentist then asks the child, "What do you need?" Action. The child may just need a brief rest, to swallow, or to stretch their mouth. The dentist addresses the need. Reassurance and restart. The dentist confirms the child is ready and says, "Thank you for using your signal. When you put your hand down, we will start again." So, benefits of signaling include reduce anxiety. Knowing they can stop the procedure at any time greatly lowers the child's baseline anxiety and their anticipation of pain. Prevents misbehavior. Instead of struggling, kicking, or crying behavior that disrupt the procedure, the child learns to use the acceptable, agreed upon signal. This channels uncooperative behavior into cooperative communication. Empowerment. The child moves from being a passive recipient of a care to an active participant. They feel like a partner, not a victim, which reinforce a positive attitude toward future appointments. And the fifth is euphemism. This technique involves the strategic use of word substitutes to avoid stimulating fear. Application. This is the core of a second language. By substituting scary words with the neutral or fun euphemisms, you manage the child's reaction. So instead of "I am going to give you a shot on your gum," use spraying sleepy water on the tooth, or putting the tooth to sleep so it can't feel anything. Some practical examples include the scary word is needle or shot. Euphemism to use sleepy water or raindrop. "I'm just going to spray a little sleepy water on your tooth so it can take a nap and won't feel anything." A scary word drill. So euphemism is "Mr. Bumpy Brush" or electric toothbrush. This is our electric toothbrush that gives the sugar bugs a shower. Then the scary words suction. Euphemism you use "Mr. Thirsty" or vacuum cleaner. We are going to use "Mr. Thirsty" to drink up all the water and spit so your mouth stays dry. Rubber dam clamp should be scary word. So use raincoat holder or ring. So this little ring helps hold your tooth's raincoat to keep the tooth dry. The scary word pain or hurt. Use pressure or wiggly feeling or push. You might feel a little push or wiggly feeling, but it will go away fast. Then the word extract or pull. Use euphemism wiggle a tooth loose. So we are going to help your baby tooth wiggle itself right out so your big tooth can grow. Now age appropriate application. So you have to use euphemisms according to the age. So effectiveness of the euphemism is tied to the child's age and level of comprehension. Preschool children, euphemisms are most effectively used with preschool children aged 2 to 6 years because their thinking is highly imaginative. Giving life to "Mr. Thirsty" works perfectly with their worldview. Older children, use with older children may be perceived by the child as talking down or being dishonest. For an 8 to 12-year-old, the approach should be more direct but still gentle, focusing on what they will feel. You'll feel pressure rather than childish nickname. Importance of consistency. It's crucial that the entire dental staff, which include dentist, assistant, and hygienist, is oriented to the use of a second language and use the same set of expressions. If a child hears sleepy water from a dentist but then hears the assistant ask for a shot, the trust built by the euphemism is immediately broken and anxiety increases. That's it for today. I will give you all the reference at the end of all the non-pharmacological behavior management techniques. If you want this PDF or any other PDF, like, share, subscribe the channel. New videos on Sunday, and we are uploading topic of the week shorts which are very important for your revision and competitive exams. Thank you.